Mohali campus completely shut right now, Sowmya?
Yes, it is, Dr. Joshi.
Okay.
Why don't we start off? I think there is some issue with mobile logins to the session, but I think in the interest of the others who have already logged in, we should start off the session. Dr. Joshi, Manish Ranjan, thank you so much for agreeing to be part of the next discussion in our series on COVID preparedness. As we all already know, that considerable number of people do not need institutional care, and they will probably be home confined or quarantined under supervision. So this webinar was to just try and understand some lessons about what we can know from things like home care. Dr. Joshi is the follow Homecare and has been leading a very successful team in this direction. And Manish Ranjan is the co-founder of Nanohealth, which is primarily working in non-communicable diseases, and he is quickly kind of changed course to also address COVID, which is actually infectious disease, and it'll be interesting to know his journey. Dr. Joshi, I would like to start off with you in understanding what is the role of home care, given that COVID has thrown a lot of challenges right not being and also a lot of so Dr. Joshi, before you start, I just want to say Manish, uh, go ahead, Dr. Joshi.
Okay, Sowmya, your voice is breaking somewhere, but I'll kind of get the gist that your question was largely around the role of home healthcare during the COVID times. So first of all, thank you for inviting me to be part of this panel, and thank you all the viewers who have joined in here. And always a pleasure to have some good colleagues and some bright stars in the field of healthcare technology there on the same platform. So as you know, home healthcare still is very nascent in India, and it has not been accepted as a mainstream complementary avenue for delivery of healthcare in India. And I think it is in moments like COVID that people will realize that how vulnerable our entire hospital-based model of healthcare delivery system is in India. And we are seeing that one illness and the entire healthcare delivery system is overwhelmed because completely focused on institution or hospital based. So before I move further, I hope everybody is able to hear me clearly. Sowmya, Manish, are you able to hear me clearly?
Yes.
Right. So I think that's the opening remark that I want to make. The organized play is just about 5. Most of them are concentrated only in the tier 1 cities in India. Obviously, the initial reaction of the entire corona or COVID piece has been of fear and fright, which has kind of pushed the home health care providers to the back seat. They are also afraid going into homes. But if you ask me what is the role, then I see two-way role of the home health care services at the times of an epidemic like this. The first one is, while the entire machinery is focusing on the management of COVID and COVID-related illness, we have to remember that the other illnesses like cancer, like renal failure, like strokes, like diabetes, blood pressure, all other illnesses or daily illnesses, what I would call in India, they are not going to stop. They are not going to stop. And therefore, we need to create a mechanism to address at least the non-emergent, non-procedure based needs of these conditions to be addressed in an ecosystem beyond hospital. And I think this is where home healthcare can play a significant role, because we have to understand within COVID, 20% of these people who are going to be needing high-end care, those numbers, if we take even very conservative numbers in India, they will overwhelm the healthcare system, that is the hospital-based system. So large effort has to be done in reducing that inflow from coming in, both corona-related and non-corona-related. I think the first important role play for home healthcare providers is to how to continue the care of the existing illness within the community beyond hospital. As far as COVID is concerned, I see 2 or 3 important areas for home healthcare to play. First, obviously, is to identify the vulnerable and at-risk population. Most of the home healthcare plays around the elderly care in the community at the current time, and they are the most vulnerable. And if we can continue to manage their pre-existing illnesses well, continue to educate them, continue to keep them isolated, continue to help the people in the family to understand that these people are at risk and they have to be kept as isolated as possible from the other community or people, I think we would have done a good job in reducing the number of high-risk patients in the community acquiring corona, because that's where the highest mortality is there. The second one is a large proportion of the COVID cases are going to be mild to moderate. That is 80% of the illness. And these really do not need hospitalization. So how do we take care of them before they... Everybody will always be home, rather than going to a stadium or going to a school or going to another makeshift hospital. The place of choice and convenience and comfort is always home. So I think mild and moderate symptoms people can be conveniently managed at home, because there is very little medical care that you need in this. The third important area that I see the role for home health care is transitioning the COVID patients back early. If the numbers overwhelm the healthcare system, we have to find a way of reducing the length of stay of patients within the hospitals. So people who have been on ventilators, people who have been there on non-invasive ventilators, how can we transition them early at home by providing oxygen support at home, by providing non-invasive respiratory care, by providing respiratory rehab at home, and also continued monitoring at home. I think these will be the areas where home health care will play a significant role during COVID times.
Thank you, Dr. Joshi. And so I think managing persons with chronic disease or a non-communicable disease is different, but they are dealing with COVID, which is actually a communicable disease. So, as a medical professional providing remote care, what are the kind of preparedness they should have in terms of training the patient that is caring, and also the complete environment, that is the home environment? What is the kind of protocols, education that they will need to be conscious of if they are going to manage somebody with COVID-19 at home?
Okay, so let's understand, as far as home quarantine is concerned, who should be considered for home quarantine, why should they be considered, and how it needs to be done, right? So if I look at from the point of view of who, so the first one would be where there is the highest risk of acquiring this infection. So they may not have had any exposure to any kind of suspected or diagnosed case, but they are at highest risk. These are your elderly people with non-communicable diseases, people with established risk factors like heart problems, lung-related problems. These people must be kept in what is called as self-quarantine to reduce the risk. The second one is for a known suspect, mild to moderate symptoms. And as of now, you don't have a diagnosis established, because it takes a couple of days for the test, etc. to come back. Now, these people immediately should be put in for self-quarantine. The third one is an established diagnosed case with mild or moderate symptoms, not the severe symptoms. Symptoms like just running nose, fever, weakness, little bit of diarrhea. If these are there and there is even a diagnosed test which says that you are COVID positive, these can still be managed at home, but as long as the concerned authorities are informed and they are able to track these cases in effective manner. Right? The next subset is going to be on people who have been exposed to these people. That means either exposed to a carrier who has traveled from abroad or somebody who's diagnosed case. This could be the family members of the person who is who has gone through either of these situations. Now, these people also need to be in isolation. There is no point in just having somebody who's come from London staying into homes and everybody else who's coming into contact of this person is freely moving on. So all of them need to be in quarantine, and from the first day of contact till 14 days is where this quarantine period is supposed to be there. So I've told you about who are the people and why they need to be quarantined. There are 2 or 3 important things. One is to reduce the risk of acquiring the infection. That is for the vulnerable. Second one is to prevent the spread of infection, either to yourself and your family or to the community. I think these are the 3 important reasons why which we need to do the quarantine. And the fourth one is not to overwhelm the hospital ecosystem with mild to moderate symptoms. If we are able to understand these 3 reasons, home quarantine is an extremely cost-effective, convenient and comfortable avenue to address a large number of cases in the community. Now, what is needed? I think there is very little medical as such into this, except the monitoring part. What is needed is, one, a mechanism to monitor, second, enforcement, okay, and third is needed in terms of ensuring that there is information that is flowing back and forth. So if I look at how do you prepare for isolation and what are the important things that you need to do at home, the first and foremost would be make sure that if you have pre-existing illnesses, you have the stock of things for yourself. You have a good first aid box with you. Third is the area where you're going to be isolated. Make sure that this is an area which is well ventilated and well lit up. It has an attached bathroom so that this person doesn't come out frequently. Then the next will be around the allied things and the people who are there in the family. They need to be conscious of the fact that they are at a risk of getting the infection. They are also at a risk of they are also a potential source to transmit the infection. They have to reduce the contact. So it's better to have just one single point of contact within the family is going to be interacting with these people who are put into isolation. Now, when you put into isolation, you have to try and make it as comfortable so that the compliance is better. So which means that the minimum thing would be having a television connection, because just staying in a room is not easy. Connected, some sort of entertainment is available for people. Internet should be available into that room so that they can connect and talk with people. They can do conversation with people. They can look up for certain things. So do you have the medical needs, which is as far as pre-existing illness is concerned? You have the hygiene needs, which I have talked about in terms of cleanliness and reducing contact. You have emotional needs. And this is the biggest challenge that people are facing. When they don't have a problem staying in the room, but how do they pass the time? How do they keep motivated that, one day is past, another 13 need to go into this situation? How do we take care of this? So I think there are a lot of good initiatives that have been done in this area, and I must highlight one of them, which one of my friends from Bangalore has done. His name is Dr. Jagdish Chakravarti. He's an ENT surgeon. And through a crowd-funded thing, he created an app and a platform through which people can actually enroll free of cost for home quarantine. And within which there is a day-long program that is there. There are 5 scheduled calls. And these calls are from a healthcare provider. There's a call from a motivational speaker or an artist or somebody who's going to motivate the people. You also have a call from a wellness coach into this. Somebody from the entertainment fraternity. There have been film stars who have made calls to these people. That most of about 300 people who have taken care, who have logged in and have been using these services. And some amazing feedback has come back from the people in terms of what their experiences is. If you ask me quickly, there is very little medical as such, but what is important is if we are going to be taking care of a diagnosed case of COVID positive at home, then the monitoring and data sharing becomes extremely important. So what elements do we need to monitor? And that's where technology can play an important role, and Manish can add on to that. The things like getting the symptoms coming, getting the vitals data coming to us. The third one important would be, if you really want to track, is the mobility and movement of the person who's COVID positive. So can we do tagging for that into a restricted geography and track the movement of these people? And this has to be updated on a daily basis and shared with the nodal authorities so that they have a track. What is important in home quarantine is it is not just, especially for COVID positive cases, if you are going to be doing home quarantine, it is not about just self quarantine. There has to be an effective monitoring mechanism, because otherwise you will think that somebody has been put into home quarantine. So people are not going to comply with it with sincerity. Now, in entire gamut of things, what is missing in our structure today is that home quarantine is mentioned as one of the avenues in the care pathway of COVID patients. But there is no authority which is going to be responsible monitoring. There are no agencies which have been delegated to actually supervise and monitor this entire piece. So, as home healthcare companies, as an association, we have given a representation to the government out there in home quarantine. But obviously, our bandwidth is limited, and these numbers will do, and this will need some kind of support for us to scale up and reach out to that number of people out there.
Thank you, Dr. Joshi. I'll just move and ask Manish Ranjan about his journey. Manish, you started Nanohealth right after your ISB program, and then you have focused your attention a lot on the non-communicable disease with the change in disease burden of India and globally. Then, with the pandemic, you have been faced force change and then reached some of your focus on dealing with infectious disease like COVID. Tell us a little bit about your journey so far.
Thanks, and thanks to you may want to mute yourself because a lot of noise. Sorry, no, yeah. Am I audible? Yeah. Okay. Cool. So yeah, I mean, thanks for the invitation and good afternoon. Thanks everyone for joining. So basically, early on, kind of when we realized that non-communicable disease and doctor added how important it is to continue to manage them while we are, addressing this big problem with this big pandemic right now. That it's more about care coordination again between various different parties, and for us traditionally health has been meaning only doctor. Now I think realizing that it's like there's a doctor, there are nurses, and mental health. The entertainment itself plays such a big role in how the doctor just explained right now. So there is a whole entire care team which kind of addresses and the problem in full. So focusing on just one, aspect is just not enough. So as we are continue to work on that, the whole idea was about how can we engage people, how can we share the data over a period of time. So basically, we have a longitudinal data that we have, and our approach was more towards like coming up with some kind of foolproof solution where we at least know in the entire health journey that where the person is lying at what point of time. And so then we spent a lot of time and energy in building actually the digital platform to do that. And suddenly when this COVID came, so we were like, okay, well, it's not the same, but like many of the parameters that we are talking about is actually they're all pretty much health parameters. The symptoms may be different than what we traditionally see in non-communicable diseases, but they're just symptoms. And basically, the configurability of our solution actually allowed us to kind of quickly, tweak our solution to address this particular pandemic. Now, actually, in terms of the capture daily monitoring that we talked about before, so we already have we already always had where actually you can capture all kind of symptoms for the disease or any disease, and so we just configured it for COVID-19. And also there are other very important things like care coordination, then be it the video consultation with the doctor, be it the self do it as a patient or even as a like a health worker who is managed a lot. We already had so-called community health worker model designed before, so we could tweak quickly that as well. So yeah, so as the first solution we built was actually a symptom, checker, which is like, you can put in all your information and it will throw your not only your risk, but what should be your next step as well. But as we see, the challenge growing, we also built, the tracking of the people, that, the GPS tracking of the people, so that the people can't move out the, the geography. But that has a loophole, and we always knew that, and basically we I mean, the loophole was that if someone actually kind of leaves the phone and moves out, then basically there's just no way to kind of get capture that patient. So we kind of partnered with the hardware providers and all. We actually have come up with a foolproof solution where you can actually who of quarantine, so they can actually wear a tag on their arm, and that kind of links directly with your app, and basically that ensures that the patient is never far away from the phone, and the phone GPS location is anyway known to the law enforcement. So while it also addresses one problem, which is like, there are basically two different departments even from the government who is actually looking at it. Like, one is law enforcement, the other is now somewhere we have also been able to kind of merge these two together, where now each stakeholder is able to kind of see their own information in the way they want it. While the data is being captured in real time, the alerts are being raised in real time. The monitoring is happening, and basically the moment you reach a certain threshold, the right stakeholders are automatically informed that, hey, your risk is growing, and basically this person needs a lot more, I would say, care than anyone else. So yeah, so that has been, I would say, like our journey in terms of how we kind of move from so-called non-communicable diseases, going like a very open approach towards a platform, and that we could quickly configure it to support the problem at hand. Yeah.
So Manish, how are you driving adoption? Because I think what this particular problem is still a public health issue at this point. I don't think private participation, except for some parts of diagnostic, has been incorporated. So, what has been your priorities in terms of making sure that some very useful product like yours is being adopted for immediate, kind of response?
So I think, I mean, as we are in discussion with, say, various stakeholders, right from BPIO to various states, decision makers, influencers at different stages. So that's the one discussion. And again, those discussions are in multiple states now. I think that the whole way, the way things are moving so fast, even for the decision maker, it's like, hey, what next? So yeah, so I think for us also, like, working with hardware and all, it took a few weeks to actually work, because we had never like done that before. But yeah, all of that is done. So basically now we are in a stage where we are actually showing the solution to as many stakeholders as possible. We're getting very positive feedback, and basically I think in the days to come we'll see more and more news about the partnership and implementation of that. We're already working with like other NGOs in Sicily, where actually they are capturing the symptoms every day. Yes, alerts are being raised and informed to the health workers directly. But yeah, I mean, like, there's a difference between a piecemeal or fragmented approach that we have taken in the past regarding healthcare, versus now where we are talking about like a holistic, integrated, comprehensive solution. So yeah, I think that's where we at this point of time, and I think the next days and weeks, as the situation is evolving, moving on.
Okay. Thanks, Manish. And I have one question here from Sakshi, which would be for Dr. Joshi, and then I'll take that and I'll come back to both of you with another round of questions. This is Sakshi from the class of Advanced Management Program for Healthcare 2021. She's the founder of Helium.io, a startup, a healthcare startup. Her question is, Dr. Joshi, what do you think is the role of domestic oxygen concentrators? I'm asking because nobody's talking about them, whereas everybody's talking about ventilators.
mute, mute the.
So, Sakshi, thank you. It's a very relevant question. First of all, I think domestic oxygen. So, if you look at in terms of the volumes, criticality, and the need, right? See, today the entire ecosystem is working about 20% of the entire COVID cases, about 5 to 10% of them who would actually land up on ventilator and who would require institutional care. But if you look at it, quite a significant who are there will require oxygen therapy. And those who are going from moderate towards the severe will require oxygen therapy with non-invasive or ventilatory support. So in terms of the volumes, the need for oxygen therapy is going to be humongous. The good thing is that given the prevalence of COPD that is there in the community, people are aware about the need of oxygen cylinders. There is at least a mechanism of oxygen cylinder production, supply, etc. In the same manner, oxygen concentrators in the last couple of years have become a good alternative for people who were traditionally using oxygen cylinders in India. And it is being used quite commonly at homes people. But obviously, affordability becomes a challenge for quite a few people in terms of buying oxygen concentrators. But I agree with your point that as much focus we are doing on ventilators, probably we need to do a little more focus in ramping up the capabilities and availability of oxygen concentrators, because the need in terms of the volumes and the number of patients who might need this, both during the acute phase and also during the convalescent phase when they are recovering, will be much higher.
So, I will now ask participants to send their questions. Please use the Q&A section to do that. I have another question here, and then after that, we'll do another round of question to the panelists, and then come back to the questions by the participants. Joshi, what are the behavioral factors affecting home quarantine? And after that, Manish, I want to invite you to weigh in coming from the technology.
Sorry, I missed your thing. Can you just repeat the question to me?
Basically, I think the field committee would like to understand what would be the behavioral factors affecting home quarantine, which I think partially addressed the question, but I think more specific answer is what Devi is looking for.
Okay. So the first important behavioral factor is denial. Right? I think that's the most important thing that we come across whenever there is something like this which is being imposed out of a sudden, and you are otherwise feeling okay, you don't want to accept it. And I think that behavioral challenge is the first to address, and how soon you get people to change their behavior. Once that is accepted, then you start looking at what are their common areas of need or worries that are there. The first and foremost is loneliness. I think this is the most important factor. Particularly, you're talking about whom are we addressing? We are addressing either the young and fit ones, right? For them, loneliness because of WhatsApp, Instagram, Skype, etc., is not such a big problem. But if you look at the elderly, for them, not having anybody from the family around and not engaging into a physical conversation or eye contact, it's a big zone of discomfort for them, right? They like to touch, they like to feel, they like to hear, right? So I think this is the second important thing. The third one is the given fact that this doesn't have a definitive cure, right? So there is this entire anxiety piece, because you don't know if you land up with it, what is going to be your outcome. You do not have any statistics, you do not have any certain thing to tell you which trajectory you are likely to take. So this anxiety is another important behavioral piece which is there. And the fourth one is sometimes people giving up and landing up into depression, thinking that, you know, at the end of this part of life, this is what had to come to their way. particularly elderly or people who have been facing certain chronic diseases, etc. So I think these are the 3 or 4 important areas that I would look at from a behavior perspective to be addressed.
Manish, do you want to add anything to this?
I think that pretty much answers. I mean, like, yeah, I don't have anything to add on that. Yeah.
Great. Thank you. So, next question is, there's a guideline released on telemedicine by POG in suppression with IMA and WHO. How do you see the guidelines being implemented in the current situation?
Right.
So, Dr. Joshi, this is with regards to the guidelines that have been released, and then they want to understand your views about how it is
So Sowmya, I seem to be losing out your sentences for some reason. So probably you need to be coming closer to your mic, or you're closer to the laptop, if that would be better. And
Sorry,
Do you want me to repeat?
this is a bandwidth issue. So, this is with regards to the telemedicine guidelines.
so is this question to me or Manish? I think Manish is better placed to take this, but I can add on once Manish finishes his.
Why don't you take this?
Let me take a shot. Yeah. Sure. I think, see, telemedicine, there's a lot of confusion around telemedicine before. That what is allowed, what is not allowed, there are different statements saying different point of view. While everyone realized that there is no option but to leverage telemedicine if you want to bring help to people who can't be. I think what these guidelines have done is brought level of common understanding both for patients and for the medical fraternity. So yeah, pretty much covering the video consultation, but what this has also done is like it has also identified the limitations of the various ways of communication we had or doing a video. And also, it has given accountability of each the very important thing that it mentioned is it's the responsibility of doctor to ensure that the patient is aware of their they must be sure that the patient itself is talking about their own health. So I mean things like this, it has actually ensured that I would say it's still not it's like a closed jacket, but very close proper accountability on each of the various providers, stakeholders in the entire health ecosystem. So in terms of, yeah, I mean, like definitely the interest have risen significantly. Like in called old partners there, let's do the teleconsultation now, which we were looking at before. But yeah, apart from that, I would say still the use is not. I mean, like one reason why it didn't pick, I would say, even before was that we like even from the patient's perspective, it's not like very well accepted at this point of time. So I would say the number of consultations is still kind of low, but from now onwards, it's just going to grow because I mean, more than anything, it just add a lot of convenience to people. So that as the trust factor improves over a period of time, so will the users and the impact of telemedicine. And actually, it's a win-win for the entire health ecosystem because the patients would actually crowd less at the hospital. It becomes a lot more convenient for them, for the doctors also. It can actually, they will have a lot of data which not only available, let's say, in the various piece of papers before. I mean, they will analyze and take a lot better stab at the diagnosis than what we were able to do before. So, I mean, yeah, so I think it's a very positive move, very timely move from the government to actually address the doubt and anxiety about this pandemic. I think things are going to just improve from here. Yeah.
So great. I'm going on to the next question. This is a clinical question. Namita Sharma wants to know if somebody who was how about developing a checklist-based escalation from hospital to hospital, home to hospital care? So patient education about the red flags of the disease will be required, so that the worsening patients can be addressed timely. And I also would like to add another question from Sandhya Chembolu, who is asking if patients who are COVID positive got discharged after COVID negative, would they still require home quarantine after being released from the hospital?
Okay. Can you hear me now? Yeah. So I'll just add a small point to what Manish said. And I think there were two barriers for the entire telemedicine piece. The first one was from the patient side, not being convinced that this is better or comparable to a physical visit. And the larger and more challenging barrier was from the clinician side. They accepting that technology can actually deliver what they are physically doing. I think what COVID has done is, to me, this is a watershed moment as far as telemedicine is concerned. On both these ends, and particularly on the clinician side, because they are losing big time revenues now, right? And they are realizing that, man, we should have done this many years ago. Because anyway, your physical examination has changed drastically from what it used to be earlier. You are much more dependent on labs and imaging for critical decision making than your palpation and percussion and auscultation. Right? History taking still remains, and lot best history taking can be done through very standard protocols, formats, etc., available through telemedicine. So I think this breaking of the barrier has been done by Corona very significantly, and it has been done at a global level. So there will be tremendous adoption as far as technology is concerned on the clinician side. And if the clinicians accept, then formulating the guidelines will become easier, because they were the people who had a lot of objections on what can be done, what cannot be done into this. So I think this is the opportunity to use the clinical people and the leadership to extend their backing to whatever advocacy is being done as far as telemedicine is concerned. On the patient side, I think patients have realized that this is a far comfortable and cost-effective way, and probably much more easier to access a doctor than what it is going through the physical mechanism. So both these things will significantly help the telemedicine piece. Now coming to the next two clinical questions, the first one is, how about home checklist? So this is being done. So when we are enrolling anybody, as of today also, there is first is a standard screening checklist. Now, most of the people who are doing telehealth are first running through that and screening for a possibility in terms of exposure to COVID or risk assessment for acquiring COVID. That is there. And secondly, for if you are there in home quarantine, you have certain things that you need to be documenting on every day. Is your vitals checked? On what frequency it needs to be? Certain symptoms, have they been locked in, etc. or not? Have you done movement? How many steps you've taken? What is the timing of the food? What is the content of the food? Have you engaged into any positive activity in terms of a group activity, group discussion, etc.? So yes, there are certain standard checklists, and obviously the most important thing in terms of keeping people motivated and positive towards these isolation pieces, if you can create a day-wise plan for yourself in the form of a checklist and continue to tick those, and somebody can assess and tell you did well today, you lagged something behind yesterday, these are the areas to focus upon. So obviously that is a great tool to implement. The next question was about somebody who was COVID positive and was treated in the hospital, and after two tests, which have been done 24 hours apart, have been tested to be negative, and now is discharged from the hospital. Should he be still kept in quarantine? Is my understanding of the question correct, Sowmya? Okay. So, if you ask me, is there a standard guideline? I don't think there is a standard guideline towards that because people are still understanding. As you must have seen, in a couple of countries, people who tested negative are also turning positive after some time. So this is the time of utmost precaution. And why I say this is because I think it is better to be safe. And in any case, if somebody landed up in the hospital with COVID, obviously mentally, physically, and clinically, on all these three fronts, he'll take some time to recover. It's best to keep somebody isolated. Two reasons for it. One, you don't know whether the virus is going to recur. The second thing is they have been there in a very high risk zone in the hospital, where every single person is dealing with multiple people who are either suspected or exposed to COVID, right? And the chances, if any of recurrence in any individual, will be highest in somebody who's been in the hospital scenario. So I would say that it is safer to keep this person in isolation at least for a week to 10 days before you start engaging into an activity. If not, the least that you could do is to have a mask on the face of the person who's going back after negative test. And at the first symptom, you need to go back and check the tests done.
Great. Thank you. I think erring on the side of caution is the message, basically, what Dr. Joshi is saying. Now, this is about manufacturing. Sagar is asking, since everybody started manufacturing entry-level ventilators, do you see CPAP be commoditized? And he has a second question, which says, today we find additional ventilator and oxygen generators, even COVID hospital beds. Will this disrupt home care business?
I seem to be losing your sentences somewhere. So either you'll have to.
So the question is about will entry-level ventilators be commoditized, considering a lot of manufacturing and research in that direction is happening? And the second question was, considering a lot of hospital capacity is being built up in terms of oxygen generators and ventilators and beds, how is that going to impact home care business?
So, as far as the first thing is concerned, I think to address the potential magnitude of the problem that we are facing, we don't have any option at the current time but to ramp up. I think commoditizing would become an outcome at the end of the epidemic because there will be a lot of supply that is available to you. So I think that's an aftermath that.
I think we seem to have lost Dr. Joshi. Dr. Joshi, can you hear us?
The network is not good at his end.
We can hear you, but I think if you should mute your, switch off the video, that may help. So while we try and get Dr. Joshi back on the call, I want to address one question to Manish. I think there's a lot of move towards doctors getting onto platforms.
At home, let's try and address them at home as much as possible. So I don't see that.
Dr. Joshi, we lost you for a few minutes. So maybe it'll be helpful if you go off. Manish, my question to you was, how do you, so a lot of doctors have been wanting to get onto platforms to, kind of use platforms, use technology to consult digital. So what would be your kind of tip to them so that they are able to do this transition much better? Dr. Joshi, good to have you back. I think we lost you for a few seconds. I have asked a question to Manish, and then we'll come back to you right after that.
Yeah, I think that's a very so actually like Dr. Joshi mentioned before that one of the challenge has been adoption of technology by the clinicians. I think there has been improvements on either side. Like the clinicians have slowly the whole the environment has been improving towards adoption of more and more technology because it actually helps them. Then the second part is also even from the technology perspective, there are like a lot of gaps before, but are being now kind of addressed slowly one by one, and the technology is able to kind of mature a lot now to actually help and support the medical fraternity. I mean, we have always got as the response is like I mean this capturing, let's say, as very simple digital health data, and like why do we need to do that? I mean, like this is just for the research, but in our like with the data that we have, what we have been able to actually prove is that if we capture the digital data and actually make sense out of it and actually recommend that what next, right? Then two things happen. One is we can talk at ISB is like the customer lifetime value of increases significantly. So actually, the customer will actually be getting lot more services for a longer period of time, especially when it comes to like non-communicable long-term diseases. And the second is of course, which means basically more revenue for the providers, the doctors, the clinicians, but also it also means that the better health for the patients. Like if you go and talk to any endocrinologist, one of the big challenge for them is like the patients don't come back on time. Now, can the technology actually address that problem? And next time any patients comes and let's say shout that hey, why my blood sugar is not in control, can you actually show them with confidence that I had to ask requested you to come back, let's say 2 months before, but you are actually coming 2 months later. So you should have we would have changed your medication in between, but that has not happened because you didn't turn up. So I think and that's the transparency which technology brings on either side. So what we have is like serious cases of the hypertension or diabetes have been able to manage by like not even space because we're able to kind of give them a longitudinal data over a long period of time. So like by through a medication that okay whether the doses should be increased or decreased based on the impact of that medication. So that all of that is able to do we're able to do now. So but I mean, on one side, the clinicians are coming forward in terms of adoption, but I do believe that the government also has to play some role in it. Like the telemedicine guidelines is like one, I would say, big step towards it. But slowly, why this whole idea of why this is important for us, the impact has to be talked about in the community, and then the data has to go out, and so that will not only for like health improvement, but also how actually it impacts the business side of the clinicians and the hospitals. So once that kind of becomes more and more open, I think the adoption is further going to increase. But I mean, to be very frank, I mean, at this point of time, the way like my dad runs his own hospital, and it's all kind of shut right now. So I do see that we don't have any option but to adopt technologies that can actually leverage to ensure that we can continue the business as it was before. And even to all the discussions are what I'm seeing, any organization which had actually adopted technology in pretty much in any industry, so they are way ahead now compared to basically the industries or the organizations which never, let's say, bothered about the digital transformation before. So yeah, I think it's a big moment of change. I think after 1 year we'll actually start seeing the impact of it. Yeah, thanks, Sowmya.
Thank you, Manish. So we have a few questions about infection control and protection towards caregivers. In the interest of time, we will not be taking those questions, and we'll try and have a session exclusively around those topics at a later time. So at this point, I just want to invite Ritesh Dogra, again an alumni of ISB. He has put something together. He's put something together that's very interesting. He's crowdsourcing CT scans, COVID-19 related CT scans, and that can be offered. We hear some ambient noise. I understand that's work from home status. But yeah, if you can move to a spot that is a little more quiet, it'll be better. But go ahead and talk about your initiative.
Sure. Hi, Sowmya. Hi, everyone. Can you hear me?
Yes, loud and clear.
Great. So we started this initiative around sourcing CT scans, and this is more to do with, let's say, when we get the CT scans of infected patients, we get into the process of segmenting it. And this segmentation is done using our own software. So me and there's a guy called Ketan. So what we used to do is to create 3D imaging of shoulder and hip joints and pass it on to doctors who would then get it 3D printed and use it for their own surgical purposes. And the proprietary software which we got developed over course of time is called My Segmenter. So coming to COVID patients, what we do is we source those images. Currently, we have sourced from Italy, China, and we are also in the process of sourcing some of them from India. What we do is the entire image goes through the software, which takes a bit of time, and anterior, posterior, both the lobes we generate areas of interest and then generate 3D images around it so that researchers, scientists, doctors can actually visualize and see those images and see which are the basic parts which are infected and how does the treatment plan happen so that it gets cured of it. Now the treatment, whether it is by medications or whether it is study of lungs or cleaning it or through ventilation, how does it work on the lungs? So we have created those images, and the day we did, it has seen around 100 downloads in 5 days. And there are AI companies, and like we were talking about some time back, the world is moving towards solving problems for COVID, which is very encouraging if you ask me. And these downloads have been through AI ML companies, the likes of NVIDIA and Nikon. So everybody trying to study it wholeheartedly and get into solutions. So two things. The website is simple. It is called covidctscans.org. And there are images which anybody is free to download and free to upload. And if you require additional segmentation, then that is something which we could help for sure. We want to work with the scientific community and researchers, and hence try and develop and create solutions. The other thing is we do imaging, but we are not an AI ML company. So anybody from the AI ML community, please feel free to connect, download, and if you require any further understanding or any further segmentation of those images, we'll be more than happy to support anybody who wants to use it for any cause.
Thank you, Ritesh.
I think in a nutshell, that is what the concept is all about. And, the segmentation effort takes quite a bit of time. I think one segmenting and, creating those 2D and 3D images would take close to a day and a half to do it. Because with the limited manpower we have, I'm talking about one person doing it. But then if we require to do it in bulk, we can definitely add capacity. As we speak, we have interest from AIMS, we have interest from SVP Hospital Ahmedabad, who are willing to share their images, invest in it. And we also have some global partnerships. For example, Materialize, which has their proprietary Mimic software, has gone ahead, and this happened yesterday. They have offered their licenses free of cost to how many ever licenses we need to help segment these images, and they would be helping us from Belgium. They would be our partner helping us from Belgium to create and see those images for the EU community as well. So that's where we are. And in terms of, everybody on, the webinar, wherever you download, upload, whichever way you can help us is perfectly fine. And it is more in terms of, making the software and across studying the software. And this is not to do with anything across monetary gains. It is more, go ahead, download, upload, and, put it into machine learning software and share the insights with us.
Great. Thank you, Ritesh, and all the very best for your initiative. And then
Thanks, Sowmya.
before we conclude the session, I want to come back to Dr. Joshi. Dr. Joshi, I would like to invite you to give closing remarks and probably give 2 or 3 messages for people who are looking at home care as a initiative during this period, and people who also want to pursue this post the COVID period. Dr. Joshi, over to you for the concluding remarks.
Yeah. Somewhere the way I look at it is in every adversity there is an opportunity. One very clear positive thing that is coming out of this entire thing is adoption of health, delivery of care as far as health is concerned in India. Significant adoption, significant behavioral change is coming into that. As far as home care is concerned, I feel that this might also be one of the tipping points for home health care, where the hospitals will realize that there is so much that they can do beyond their hospitals. Existing infrastructure for doing better things than what they are currently occupying their beds with. And if the well-established hospital systems can work in tango with home health care companies and handle a lot of their non-urgent, non-emergent, non-procedure based care beyond the hospital ecosystem, we would have done a lot of favor in terms of the cost reduction for the communities concerned and a far better reach for people in addressing their needs in a far better manner as far as the need addressing is concerned. Home health care, currently, as I told you, there is a lot of fear and fright, but I think it will play an important role if the numbers grow in reducing the number of people that are going to be coming to the hospitals, and also early transitioning of people who have been treated for COVID, either in isolation centers or within the hospitals, back to the home with the respiratory support, or oxygen support, and respiratory rehab support with continued monitoring at home. So this is how I view the role of home health care into this entire piece.
Dr. Joshi and Manish, thank you for your time too, and then best of luck in having wider adoption to your platform, which can help as an enabler and multiplier effect, not only in this context, in multiple other contexts. Please, if you have any concluding remarks to offer, go ahead.
Right. I mean, like, no, I think there's a lot of learning from the questions and the fellow panelists and from you, of course. But I like we discussed. In many ways, the world is not going to be the same, and this is what I have been talking to all my friends and colleagues. We have to be ready to adapt ourselves to this new world, and definitely the healthcare is going to go through a big change. So we'll remember long that this happened, this had happened, and that's the reason why we are doing now versus things, and we are definitely out there ensure this happen in the swiftest of and in the most convenient manner for many clinicians and the providers and for the patients also. We are ready to be a part of this interesting journey ahead. So thank you, Sowmya, for allowing us to share our views. Yeah.
Thank you so much, Manish and Ritesh also. For our participants, thank you, and for your patience, especially through some of the technical glitches and bandwidth problems we experienced. I will soon be sending out details about the next webinars. The next one would be on how to set up teleconsulting, and we'll have an interesting panel who can, kind of take you through at least the 101s of it for you to start the journey towards that direction. And thank you once again for everyone. Stay connected with everything that's happening with regards to healthcare at ISB on our LinkedIn page, Healthcare at ISB, and also we have our presence on Twitter also. And we'll be putting all of our event details, educational session details, and research-led insight on these pages. Please follow us, stay connected. More importantly, please come back and tell us what is it that you want to understand and learn, not only during this lockdown or the COVID period, but beyond that also. Thank you very much to all the panelists for your time, and especially so much more happy that I'm talking to all three of you who've been part of ISB and started your management journey since this one. Thank you so much, and then participants, and see you soon in our next webinar. Bye, everyone.
Thank you. Bye, Manish. Thank you, Sowmya. Thank you.
Thank you, Dr. Joshi.